we again would like to welcome you all, and I especially would like to welcome Dr. Judy Huang to give us our talk for the today. Entitled, I understand quite controversially, Chiari Malformation is a great cover-up. And I think it'll be clear at the end.
Thank you, Dr. Luciano. Thank you very much for that kind introduction. And welcome to all of you. It's great to see so many faces here and so many people who brave the rain to actually come here and listen to me. So I really appreciate the opportunity to start a conversation with you and to share some of my insights and hopefully to get questions from you later. As thoughts come your way, please jot them down so we can definitely discuss at the end of my presentation. I do applaud Ms. Poppy for really these phenomenal efforts that she really is a driving force behind the Chiari Foundation and the outreach that is done and the advocacy that is done, because as you will see, a theme that even comes up in my talk over and over again is that we could do so much better. We could learn so much more. And that's why the efforts of Dr. Luciano and colleagues to really pin down essential research questions so that we can start answering them is really what we are all about and what we need to do more of. So I'm going to start with a little background about Chiari malformations, right, to put everybody on the same page. Because I think that everybody's coming from a different place, so I just want to bring us all on board. Start with a schematic, okay, of a mid-sagittal view of the head, okay, and so you can see that the brain is up here, but the cerebellum is the part of the brain that houses the tonsils, and it is confined to the skull here in the back. And the reason why the tonsils hanging down below the skull is a problem is because it blocks and pushes on the brainstem that's right in front of the tonsils. And the brainstem eventually connects to the spinal cord. You can see that here, okay? And the normal position of the tonsils is up here, next to the edge of the skull, but in a Chiari malformation, it herniates downward or is displaced downward. And the thought there is that in this picture, you see there's fluid depicted as the gray, okay? The thought there that if there are tonsils in the way of that fluid flow, that there's a problem with this free flow of circulation of the cerebrospinal fluid around the brain and the spinal cord. And that can lead to issues like Syringomyelia. So then you have, what does this look like in an MRI picture? Okay, so you can see on the left is normal. So you have the edge of the skull right there. And the tonsils are above it. And you see lots of CSF space over here. In contrast, in a Chiari 1 patient, you have a very small space in the back of the head or the posterior fossa. And the skull comes all the way down here, but the tonsil comes down to here. And so there's much less space for the tonsils to sit. And as a result, the tonsils push on the brainstem because what's coming through the bottom of the skull are the brainstem, normally going to the spinal cord. But if the tonsils take up space, that's potentially a problem. So remember that it's a three-dimensional relationship that we're covering here, right? So even though this MRI, this mid-sagittal MRI, which means a cut down the middle of your head, is what is used to measure the amount of tonsillar descent, that number is really just a number, and it really doesn't tell the whole story, because I can tell you there's lots of people where the tonsils are not quite 5, maybe a little marginal at 4 or 3, and they have really, really bad symptoms. And other people, that number can be 10, and they're not as bad off in terms of what they're feeling and experiencing. And so why is that? That's because this picture is just one view, kind of like Ms. Poppy was alluding to about how you measure what image you use can actually affect the data that you start with. So to illustrate that a little bit more, this is a patient I saw very recently, okay? She comes to me and the MRI reports are saying 2 millimeters, no Chiari. Okay, no Chiari malformation, okay? There's no evidence of Chiari malformation. They kind of mention it, but say basically the number's too small, it doesn't qualify. So if you look on the sagittal, okay, I'll give you that. You know, this is the bottom of the bone, the tonsils are here, okay? Really not very low in terms of how far they're hanging down. But remember, this is a three-dimensional space. So I give you here a cut that goes this way, an axial view. Okay, so we're cutting now in a view that shows the tonsils and the relationship of the tonsils in a different way. So here's the bottom of the skull, this circle, and here's the spinal cord and the brainstem. And the tonsils are really taking up a lot of space around and surrounding it. So the other thing that you can see here is that the slope of the bone is that it's not straight down like this, it's kind of curving in. So it's indenting into the tonsils a little bit more. So she's actually fairly symptomatic, even though technically speaking, it may not qualify as the definition of a Chiari. So those things are important to keep in mind. So many of you are familiar with how varied Chiari malformations can manifest in different people. So many of these symptoms are familiar to you all and to people that you know who have Chiaris, but not everybody experiences it the same way. So this list is an exhaustive list, but this does not mean that every patient has all these symptoms. And the other thing is that patients experience these symptoms in different ways. Okay, so you've heard of the headache, you've heard of the head pressure, but some people have head pressure behind the eyes, some people it's near the ears, behind the head. So it can be different. Then there's sensory changes. Sensory changes, some people can have trouble with, say, temperature. Some people can have trouble feeling something that's in their hand or something, rubbing up against a leg. Then there's visual disturbances. Frequently people talk about having a difficult time focusing or that their vision jumps a little bit. Some people just say it's blurry. So it's hard to be the same in every person. Then some people experience hearing loss. That can be even the first symptom sometimes, or ringing in the ears. That's another common one. And then swallowing problems can be in that spectrum of lower cranial nerve involvement. So swallowing pills becomes a problem, or swallowing water, or other things. In the worst case scenario, it would lead to choking. Okay, even just having a normal meal can lead to some problems getting food down. And then there's poor coordination. Poor coordination is a one that can be very varied, okay, and not obvious to people, okay? So, some people just think, so they weren't cut out to be, an expert athlete. So they don't think anything of the fact that they can trip on their own feet or other things like that. So if you don't really ask, you don't really get a clear insight into what that could mean for different people. Then there's balance difficulty, dizziness, poor sleep, memory problems, loss of concentration, fatigue. Okay, so a lot of this is a long list, and it's all this stuff that some people have some symptoms, some people don't have any of these, and it ranges person to person. And so it is actually estimated that 1% of the population can meet the radiographic criteria. So that if you look on their MRIs and use the definition of 5 millimeters of tonsillar herniation, there's actually a lot of people out there that meet the criteria. However, most people don't have symptoms at all. And so that's more than the majority. So it's 70%. Okay, and that's why I've heard over and over again that there's patients who say their doctor doesn't know anything about Chiaris, just told them, don't worry, it's not a big deal. Well, the situation is that most people, it's really not a big deal for them. And it's not something that interferes with their life, and they should go on and do everything they want to do in sports and work and, take care of their kids and anything they want to do, and they actually don't have a lot of problems. But for others, they have a lot of those symptoms that were on that list that I just showed you. And when it does affect them, it can be very dramatic and very problematic. Okay, there's a slight higher incidence in women than men, not very much, but more common. But a very interesting statistic is that the average time from the first visit to the actual diagnosis being made is actually several years. And so that goes to show you how difficult it is sometimes to even get an MRI, to even get to a diagnosis, right? That, people just kind of say, something's not right. I'm very tired all the time, or I feel foggy, or, I can't concentrate, right? And those are kind of things that people notice, and something's not right, but it's not very clear why that would need an MRI per se, and so they go on, and it takes a while. The other things that are commonly mistaken for Chiari symptoms are listed here. So people are told that they have migraines, or they have fibromyalgia, or they have depression. And the reason for that is because symptoms such as headache, or memory difficulty, or dizziness, or clumsiness can actually be very nonspecific, meaning dizziness is one of those symptoms that can actually imply all sorts of problems, some of which is not neurologic at all. So it's tough, actually, for some people to get to the point where they have a diagnosis made. In addition, there is a lot of association between diagnoses that are linked to psychiatric problems. So for instance, in the pediatric population, many patients who have Chiari's are also diagnosed with ADHD. That's about a fifth of people. And then in other diagnoses include anxiety and depression. And then in adults, it's also quite common to have the diagnosis of anxiety or depression along with the diagnosis of Chiari. And it's not easy to tease out, is the chicken or the egg kind of thing, or it's that, is it that you really do have anxiety about your Chiari type symptoms, right? So they're kind of linked, but it's hard sometimes to tease out what's what. It is also another interesting statistic that about a quarter of people can pinpoint an acute traumatic event as the cause of when their symptoms kind of started, okay? And sometimes that's a concussion, or like a neck injury, like a car accident, having a whiplash, or having a bad fall, like slipping down a flight of stairs, or tripping on the ice and hitting the back of their head or forward, some kind of traumatic event that actually leads to it all. That actually is not uncommon. All right, so then you've probably all know about this, but the main treatment for Chiari patients who are very much impaired by their symptoms is decompression surgery. So obviously, of the people who are not troubled by that list of symptoms that I showed you, who are relatively asymptomatic, they don't need this, okay? But if they are selected for surgery, the decompression surgery that is done is illustrated here in this way. So in the picture, you can see on the left that the tonsils are hanging down low, and then here is a cross-section at the neck, which is the top bone in the neck is called C1, and the second bone is called C2 over here, illustrated here. And then in the surgery, what happens is that there's a craniectomy, which means part of the skull is removed, and part of C1 is removed, and some people get C2 removed. That's is not needed very often, but some people do get that removed. So the primary focus is removing this piece of bone here and then C1. So this is the schematic cut through the middle. The next picture is as if we're standing from behind, okay, so we're looking at the back of one's head, and you can see now the orientation is different. So here is the C1 bone with part of the back of the arch of C1 removed. C2 here is left intact. And you can see that the dura has been opened. So the dura is the covering of the brain, right? And that's been opened, and you can see the cerebellum here, and these are the tonsils that are hanging down below the cerebellum. And what you don't see in front of these tonsils would be the brainstem. That would be what you should normally see is the brainstem, but the brainstem is covered up here by the herniated tonsils. Okay, so this is one of the typical openings of the dura. And then what happens after you open the covering of the brain, right, all this fluid comes out, you definitely need to close it back up again. So what is done is putting in a dural patch, and that's called a duroplasty. Okay, and a dural patch gets sewn in and basically expands the dura. So it's kind of increasing the size of the space where the tonsils can float around. And presumably that allows the fluid, the CSF fluid, to flow a little more freely through that space. Now I'll point out here that one of the main points of constriction of the tonsils is actually a piece of tissue called the suboccipital ligament, which is shown here. It's shown here as being divided, as being cut. So it would run this way. And that's a piece of tissue that is very kind of tense, and it's soft tissue, but it's pretty stiff, and usually causes that restriction on the tonsils along with the dura. So there are some people who only remove the bone and cut the suboccipital ligament. And there was a time when this was very much in vogue of scoring this ligament and just releasing that band of tissue in addition to removing the bone. And so there are definitely people who get the procedure where the dura is not opened, okay? So in terms of what is used for a dural patch, there's a lot of different materials that can be used to create that patch. So the first is actually the covering of the cow heart. And that was something that was used for many years, and it's all sterile and stuff, and there was no mad cow disease reported or anything like that. But it was used for a while, and then the recent use is with a non-synthetic dura substitute that is actually also made from cow, but it comes from the cow skin, and it's actually much more easy to manipulate than the heart, the covering of the heart. And so that's been used very often in recent times. The other choices are actually material from one's own self. So the pericranium is this layer of tissue that's outside the skull from the patient's own body. And so that can be moved essentially to serve as a graft. And then another choice is tissue from oneself called the fascia, which is another layer of connective tissue that's pretty strong. So there's this topic can in and of itself be a long debate of what graft material do you choose to use, because there's really pros and cons of each. And it has to do with the amount available for use, the tensile strength of the tissue, risk for infection. Those are the types of questions that can be raised. So talking about cover-ups and topics that are not well understood, okay, is this issue of should the dura be opened, okay? So I alluded to before how duroplasty seems like a good idea of opening the dura, putting in a patch, okay, creating more room for the tonsils to float, but that there are definitely schools of thought that believe that all you have to do is open the bone, get rid of that bone that I showed you, and leave the dura closed and just divide that suboccipital ligament. The reason for that is because there's really not a great deal of evidence one way or the other that one approach is superior than the other, right? Because you sort of have to study lots and lots of people to come up with enough numbers to figure out if one is definitely better than the other. And sometimes it seems like one way is better, sometimes it seems like the other way is better. And it depends on who you ask, the patient population you study, whether it's kids or adults, all sorts of things. And there's a trade-off. So in a synthesis of 14 articles covering adults, it was found that people who had a duroplasty were less likely to need another operation, okay? Meaning another operation to relieve symptoms, okay? They were less likely to do that. They were also more likely to have a decrease in the size of their syrinx, but not everybody has a syrinx, right? So the people who have the Syringomyelia, they seem like they benefit from opening the dura. But what if you don't have a syrinx? Do you benefit from opening the dura? We don't quite know that yet. However, the trade-off is that the people who did have their dura opened definitely had a higher risk of CSF leak after surgery, and even a temporary chemical meningitis. And chemical meningitis can come from irritation of the meninges or the covering of your brain because of inflammation from having your dura opened and having extra entry into the space that normally just has your brain and your CSF. And the worst case of a CSF leak is a symptomatic pseudomeningocele, like this picture. Okay, so in this picture, we're seeing a patient who's had surgery, and you see the bone is removed up to here, but this whole white collection here is fluid that sits outside the dura, outside the skull, and is pushing the skin out. And so that's actually very uncomfortable. And that's called a pseudomeningocele. And so that's the worst case situation after a CSF leak. So that makes one's recovery much more difficult, much more prolonged. And so there's a trade-off. Okay, so that's why there's still no great answer for should everybody open the dura or should nobody get the dura open, right? And so that's tough. So then let me show you a case that's extending this theme a little bit. 42-year-old woman who's diagnosed with a Chiari about 4 years ago. Her initial symptoms were headaches at the back of her head, swallowing difficulty, and some tingling in her elbows. She underwent decompression surgery, had the bone removed, had the dura opened. She didn't have a cranioplasty. She reported complete resolution of her symptoms for 1 year after surgery, but then noticed return of severe headaches. She did notice that it was a different quality of headache compared to the initial pain. She couldn't keep her job because the pain was so bad. And her pain actually did not respond to the Motrin and the non-steroidal analgesics, and even the narcotics didn't really help very much. So she was miserable. I saw her, and I proposed to do a cranioplasty on her as a salvage procedure because of a previous failed decompression without cranioplasty. So she did have her dura opened up. Okay. And postoperatively, she did experience a very dramatic improvement in her symptoms, such that they were decreased in severity. Okay, so now I'm going to shift a little bit into a topic that we don't talk a lot about, okay? And I'll point out the symptoms of this condition. They tend to be headaches that are in the front or at the top of the head, sometimes behind the eyes. The headaches are unlike the typical Chiari headaches because they're not strain related, meaning like if you cough, it doesn't bring it on in particular. There is frequently associated neck pain and back pain. Sometimes there can be unsteady gait. Sometimes there can be weakness in the arms and legs, and sometimes sensory changes. Very hard to pin down this constellation of symptoms, but these are slight, there's some overlap of these symptoms with the typical Chiari symptoms. So why did the patient improve after that cranioplasty? So let me elaborate on that a little bit more. She had something called cerebellar ptosis, or slumping. And this is a phenomenon that is illustrated in this picture, where in this picture, this is the pre-op. So you see the arrow here is the edge of the bone, and here's the tonsils below the edge of the bone, okay? And then after the bone is removed down here, the cerebellum still hangs down, okay? And there's some contact here between the cerebellar surface and the dura, which is the covering, okay? And this doesn't look bad at all. Actually, the picture doesn't seem very abnormal, but the symptoms of this can be really drastic, much like the symptoms that I described. And here's a more obvious picture of that. So slumped cerebellar tonsils can reestablish contact with the brainstem. So you see that these tonsils are now touching the brainstem and recreate the partial obstruction of CSF going through this space, and even lead to a reaccumulation of syrinx, which is down here, okay? And all this, you see how it's basically all this is hanging down below the edge of the bone as a result of the decompression. So it's basically the tonsils are kind of falling down, slumping, okay? And ptosis is the medical term. Here is a picture of someone who had symptoms like this, and it's thought here that this bulge of the dura here that we're seeing indirectly is a dural ectasia, or a weakening of the dura, so that again her tonsils are slumping or hanging down too low. Okay. So speaking about the characteristics, in terms of the headache, it's definitely different than the initial presentation before the decompression, and people are able to describe that. It can take, however, several months to several years after decompression to develop. Okay, so the length of time where it happens is inconsistent across people. It's not associated with coughing or straining, and typically there's some pain at the lower back of the head with radiation to either the jaw or the forehead area. And that's because the thought is that the cerebellar slumping pulls pulls on the dura that's in the back, and that dura is innervated by the lower cranial nerves 5 and 9 and 10, and that's why it leads to the jaw pain and the facial pain, like pain that's different than the normal Chiari pain. And so the treatment is cranioplasty. And what cranioplasty does is that it reestablishes some of the cerebellar support, so that at the bottom of the skull, instead of the bone being there, okay, that the bone is replaced by a structure, a material that lends some stiffness and actually holds up the cerebellar slump a little bit, okay? And the idea there is that by holding up the cerebellar tonsils a little bit, it can allow the reestablishment of normal CSF flow. So here is a picture of the cranioplasty material that I happen to use, and there are different kinds of material, okay? This is a picture of titanium mesh embedded in a high-density polyethylene, some kind of plastic, basically, okay? And this is chosen because it can be cut, it can be bent, it can be contoured, so it can be shaped to the individual person. And then the other thing is that it's radio opaque, so it can be seen on images, and it doesn't prevent you from getting an MRI or going through metal detectors in airports and things like that. And so I talk about this as the plate that I use. And so this is the actual picture of it. And so I always say it's not a solid metal plate. It's mesh embedded in some plastic. But this is an example. And so I bring this up because this is something that I have found useful to do in the Chiari surgery to prevent that cerebellar slumping that I talked about. But this is not universally done, actually. And so there's lots of people who do feel like they're walking around with something wrong after Chiari surgery, and everybody just kind of keeps telling them, but your surgery was successful, your surgery was fine, there's nothing wrong, the picture looks fine, you clearly had enough bone removed, you clearly had adequate surgery. And they go on and on for a long time, really in search of answers of why things are not good after surgery. And obviously it's much more dramatic if it happens years down the road, but some people it's noticeable in a shorter period of time. And I can tell you that it's very frustrating for people to be told, oh, there's nothing wrong at all, go take some pain medication, and some people get injections and so forth, and it's tough. So this is something that's becoming much more evident in the literature. So people, I think, are starting to talk about this more, and this is why research is needed, because you are experiencing yourself that there is not a lot of standardization across a lot of the things that we do with Chiari malformations. And sure, it's not one size fits all. Everybody's different, okay? And but the more we learn, I think the more people we can help. And so that's meant to stimulate some discussion. I wanted to thank my research fellow for helping me put the slides together, and let's open it up to discussion. I would ask that you try to ask questions in sort of general terms that would apply to everybody, rather than sort of making it very personal, just so that everybody's privacy is respected and so forth. Okay, great.
When you do a lot of these scans, how often do you do upright scans, and what do you find that's part of the consensus of what is required for seeing these things?
Yeah.
And can you just discuss that in general?
Yeah, I have not found them to be particularly useful, the upright scans, because it still represents a snapshot in essence. Yeah, sure, it's upright is another position rather than supine, but sometimes the picture just doesn't tell the whole story. So I find it much more useful to actually really delve into the symptoms, like the time course, how did it develop, what does it feel like, so. Yes?
Thank you, by the way, that was very informative and engaging. My wife was recently decompressed, and she has migraine. She had a concussion 3 years ago. Hit her head on a doorknob. Within 6 months, she started having weird symptoms. I had MS, so I thought, well, maybe you have MS. So she got an MRI, Chiari.
Yeah.
My question was, like, what happens during the trauma? Does it literally shove the brainstem over? And if she were to have another concussion, and she's better, by the way, would that risk
Right.
forcing it down?
Okay. Yeah, so the way I think about it is, back to that whole idea about it's a three-dimensional space, right? So I think that when you have a sudden trauma, you're not in a position to hold your neck and protect your neck, so that there is a sudden acceleration, deceleration, or a change in position. And basically it is a little bit of a sort of banging of the tonsils against the brainstem, stretching the lower cranial nerves potentially. So it's literally like hitting the brain inside the skull, okay? And it's like it's similar to the idea of concussion, right? A concussion is when you slam your head into something and the brain jostles and hits the inside of the skull. But if you did a picture, you can't see damage. So same thing with the Chiari, okay, is that people who have this sudden injury, they get a picture, there's no bleeding or some kind of obvious damage, but the symptoms are there, right? So I think that's how I think of it, as why it manifests, and that it would not happen to a normal person because they have the reserve. They have because the CSF, you think of it as like a water, like it's a water bath, right? So you float in it, and so people who have a lot of CSF around their tonsils and their brainstem, they have the reserve where a sudden acceleration, deceleration may not cause that banging of the tonsils into the brainstem, but when you have the Chiari, it does lead to that. Now, with respect to the is she at higher risk in the future, if she's had a Chiari decompression, then theoretically no. So that's reassuring. Good. Yes.
So following that question, so is there any evidence of anyone that's ever had an MRI prior to a diagnosis that doesn't show Chiari, and then had a traumatic event that did show a Chiari?
Yeah. So Chiari 1s even, okay, can be caused by different things, okay? So one reason is the CSF leak, okay? So there are some people who, after some kind of major trauma, get a CSF leak somewhere along their spinal cord, and what happens is it draws down the tonsils, okay, so that they never had tonsillar herniation before, but now the brain sags down because the pressure in the head is very low, okay, so that is acquired Chiari, or a Chiari that develops for some other reason. And those are hard to find. Dr. Luciano is really good at finding those leaks.
When we ask the questions, to either speak up loud, and maybe Judy, if you could repeat the
Oh, okay.
questions so we can hear.
Sure. The question was about someone who's had a baseline MRI that has no Chiari, and then they're found to have another Chiari. Found to have a Chiari later. It definitely happens in the cases of CSF leaks. Okay, and so CSF leaks can occur anywhere along the spinal cord, and sometimes they're very hard to find. And so, a specialty center like Hopkins, like Dr. Luciano, is actually very expert at finding those leaks. And sometimes just treating the leak, you don't have to treat the Chiari, so they don't need the decompression surgery. Yes?
One of those 14 articles would have been some neurosurgery journal in 2013, 2014, whatever, with a cohort of, say, 24 patients, and they were trying to decide whether, opening the neuro was better or not. The upshot of that particular study was they couldn't really tell any difference. But in the last paragraph, they found a smaller subset of the cohort that had unexpected complications from before, during, and after surgery. And the problems that they described were related to, connected to the disorder. So in context of the brain suspension system is made of fluid and fascia, what kind of effect can we expect to see on brain slumping, brain sagging, brain hernia, brain prolapse from normal usage, events that don't count as traumatic in the normal population, but they do count as traumatic in the population, connected to
Yeah. It is true. So I think your question is are people who have connective tissue disorders more susceptible to having problems after decompression surgery and opening the dura? Is that close?
Well, also how it relates to, say, who's likely to, acquiring the Chiari pattern in the first place.
Oh, okay. I think there's a lot that we can learn still regarding the influence of connective tissue diseases on Chiari's, because it is true that a connective tissue disorder affects all the connective tissues, and that includes the tissues that hold the bones together and the ligaments between the cervical vertebrae and the skull, and so it is actually potentially complicating to remove some of those connective tissues that are actually intact. Okay, and so the contribution of the connective tissue disease to the symptoms of a radiographic Chiari is definitely there. And I think that we don't really know the best way to handle it quite yet. But the worry is that if you get decompression surgery in the setting of connective tissue disease, that the benefit may not be as long lasting, because the tissues that are supporting the skull are not as strong. So there is that worry, but I don't think we've completely sort of gotten a handle on that entirely yet, because there's more work to be done, I think. Yes?
What if the dura was open but you still have headaches 2 years later?
Mm-hmm. Yeah, so it could be that there's the cerebellar slumping, right? So, the issue would be, is there...
But you have the titanium mesh in place.
Okay. So there's a lot of I think the first thing to do is to get another picture, okay, to sort of see how things look in there. There can be a lot of reasons, okay. Sometimes there is an unexpected collection of fluid, okay, so sometimes that occurs. Sometimes there is robust scar tissue, okay, so that the expansion of the dura was limited and not overcome to a degree that is adequate to be durable. So that the amount of space that was created didn't necessarily, stay to be enough space, because the body's way of dealing with surgery, right, is to scar, right? And that's normal. That's a normal response. That's your body's way of healing. And so scar tissue means that things become stuck to each other. Things adhere, and that there is no free flow necessarily movement per se. And so there's certain people who have robust scarring, and so the space that was created kind of goes away. So that's one possibility. And then there's the other possibilities of, there's a leak, there's a fluid collection. Yes?
If you have a CSF leak in the front of the brain, like above the rhynia area, could that be a reason for the flow causing the Chiari?
So, you mean, can that be the reason for getting a Chiari?
With you said it being along the spine,
yes.
leakage along the spine,
yes.
But with the leakage being in the front of the brain area instead of
the
back.
I think it potentially. I don't recall seeing anybody like that recently, but yes, I think it's possible. Yes. Yeah. Yes.
There are some patients that have comorbid conditions, especially like dysautonomia and things that they're getting IVIG for. the increased risk of aseptic meningitis. First of all, is aseptic meningitis and chemical meningitis the same thing?
Good question, yes.
And our patients with Chiari have increased risk in the damage from the aseptic meningitis caused by either IVIG or any other things that might cause it?
Okay, that's a great question. So aseptic meningitis, yes, it does mean the same thing as chemical meningitis, correct. And so the important thing is that it's inflammation of the meninges, but no bacteria, no virus. So it's not necessary to get antibiotics, okay? So that's the first question. And then are patients at higher risk for getting that condition associated with a treatment? I don't think there's good evidence one way or the other, but I don't think so, because the chemical meningitis that happens after Chiari's is really in response to the surgery. So it's really in the post-operative period, in the first few weeks.
Sorry if I phrased it wrong. I meant is meningitis more damaging in Chiari patients than somebody without Chiari? Because I know in septic meningitis, it can cause all sorts of problems in the body. Is aseptic meningitis in these patients more damaging than in patients without Chiari?
I wouldn't think so.
Okay.
Yeah, I wouldn't think so. Yes.
So after you were to have a decompression surgery, in my daughter's case, she wound up having a dura patch, but we had problems with infection. She had scoliosis rods removed twice. So we weren't all about the titanium because we were afraid.
Yeah.
But is it procedure to like do a follow-up every year and an MRI? Does another MRI ever happen, or does it have to be triggered by symptoms that may think that you are slumping?
Sure, that's a great question. I do think that that's a very personal decision that's made between the patient and their surgeon, because I can tell you there's a lot of people who don't want to take time out of their busy lives to get an MRI, right? If they're feeling great, they don't want anything to do with it, right? They want to go on and get back to normal life, quote unquote, right? So for those patients, I choose not to get any more pictures. But if somebody is worried that something bad is happening, then sure, we get a picture. So my personal practice is not to get routine pictures, unless somebody has Syringomyelia, actually. So Syringomyelia that's the syrinx in the spinal cord, right? So when my patients have Syringomyelia, I do ask them to get routine scans, and even if they're doing well, because I'm tracking to make sure that syrinx decreases in size. Sure. Yes.
I'd just like to know, do you agree with the theory that if somebody is diagnosed with Chiari when they're young, the surgery can usually heal the Chiari so they won't have issues again in their life? But if they're diagnosed when they're older, say like when they're 50, you have surgery not to help heal the Chiari, but to stop the progression of the symptoms? And if so, what does life look like after that?
That's a great question. So the question is, are people who are older as likely as younger kids, for instance, to get reversal of symptoms or benefit from Chiari surgery? I think that it is true in general that kids are more resilient and they do bounce back from whatever insult is happening to them. So whether that's brainstem compression from a Chiari or surgery, they tend to bounce back a lot faster. So it is thought to be that they have a greater capacity for reversing a neurologic injury than adults. So I would say yes, there's that belief. However, I can tell you that if symptoms are not there for so many years, that there is still a chance that symptoms get better. That it's not just about stopping the progression of symptoms, but there is actually the hope that the symptoms will get better. I think that reflects more on the duration of the symptoms. So if somebody's had symptoms for 10 years, and then it gets worse in the last 5 months, that's not bad, okay? Because something happened in the 5 months that tipped them off, right? To know that something was changing, something was different. So I use that 5 months as opposed to 10 years, because a lot of times people have nondescript symptoms of dizziness or fatigue and they don't get diagnosed. So it's very common for me to see people who've had it probably for many years. And they're also very capable of getting better after treatment. Yes?
Sorry. Can symptoms come and go?
Yes, absolutely. Absolutely. The way I think about it is our structure changes over time, right? So as time goes by, our posture changes, our weight changes, our height changes, because the discs that are in between our bones, they dry out a little bit, and so people shrink, right? So there's the 3D relationship of your head to your neck changes over time, okay? And so there are certain situations where that is all fine, and the fluid moves around, and the tonsils don't push on the brainstem, and you feel pretty good. And then there's other times when it just starts acting up. And so I do think it's possible to have fluctuation in symptoms. Yes?
Is there any research in terms of cauterizing the tonsils or actually changing the tonsils as opposed to trying to support them?
Yeah, that's another variation of surgery, okay? That has to do with how descended the tonsils are, okay? So like how far down are they hanging? The overall assessment during the surgery of how much space needs to be created to be effective, okay? I can tell you that I do that for people who have Syringomyelia, okay? Where we are really trying to open up the space so that the fluid in the syrinx goes away. I don't do it for everybody. And it is definitely an assessment of how severe the Chiari is.
Thank you.
Yes.
Do you ever have issues with intracranial hypertension?
Hypotension? Hypo, did you say? Hypo?
Intracranial hyper.
Oh, hypertension. So that is, so you're referring to idiopathic intracranial hypertension? Probably, right? So or pseudotumor, is that the word that you're familiar with? So Dr. Luciano is more of an expert on that than I am, okay? They are somehow linked in certain patients, okay? But I don't know what specifically you're asking, but they are linked in certain situations. Not everybody, but in certain situations. Okay, you had a question? Sure? Yes.
Looking at someone who hasn't been diagnosed with Chiari, and they just let it go, and obviously they're having problems and stuff, but they do nothing about it. What is really, like, unfortunately, devil's advocate, what is the worst case could happen to this person?
Worst case is that they're miserable. Literally, it's a quality of life. It's not life-threatening, okay? Not usually life-threatening, but it's a poor quality of life.
Can't call paralyzing or anything like that, like pressure or nothing like that.
I don't think so.
Does it get worse? I mean, typically what would happen, like the tonsils is.
Right. So I've not seen a significant worsening, meaning like the number of the millimeters of the tonsils hanging down get worse. I've not seen that from just a straightforward Chiari. If it's a leak drawing down the tonsils, yes, there can be changes. So it depends.
So you say a leak, just describe that leak to me, like that fluid is actually coming out.
Right. So I mentioned the word dural ectasia. So our nervous system is covered with this dura, okay? So that includes our brain and our spinal cord, and there are nerves that come from the spinal cord, exit the spinal cord and go to carry, nerve signals to our limbs. So anywhere along that dura, there could be a weakening, okay? And fluid can leak out, literally. But it doesn't leak out to the outside world. It's contained within our body. So if you have this leak, and it's water, right, going down the path of least resistance, it can continue to leak unless it's fixed, right? Because it's just nonstop, okay? And then, so what happens is that over time, people can get the the pressure in the head can become low and the tonsils can get drawn down.
Thank you.
Sure. Yes.
On the note of that, wouldn't somebody with the CSF leak, does all people with CSF leak have symptoms? The headaches, the nausea, things like that?
Not everybody. No, no, because most CSF leaks go away by themselves. So I don't think everybody has symptoms. Yes, yes.
I just wanted to say, to just add on to his question, I'm going to get a little personal, but I had the right side of my torso, and it was getting numb, and it actually spread down, and it started underneath my armpit, and it spread all the way down, and actually it started to go down my leg. The paralysis was getting worse. And it's getting better now, but that's originally why I had to go to the doctor, and that's when they diagnosed the Chiari malformation and the syrinx. I had two syrinxes, one here and one here, and it blocked my nerves on the right side, and it actually did spread and get worse.
Yes, I was more referring to Chiari without syrinx. So I think you know that having Syringomyelia, I don't think there's anybody who would not treat that. So once you have a Syringomyelia, that's a surgical disease that needs to be treated surgically, because that is much more involved than actually just the tonsils and the brainstem. That involves your spinal cord.
Right.
So it's good point. Yes.
What would be your approach to a patient who doesn't respond to the typical decompression? They've had 3 decompressions, 1 CSF leak repair, now developed a syrinx. Symptomatically, they're worse. Imaging, worse.
Yeah. So obviously, it's a very complicated situation, and this is not the forum to be analyzing something like that. I think that really requires individual attention to look at MRIs, to look at the sequence of events, what was done. So that's clearly something's going on. Yes.
I've worked with some patients that have had inappropriate bone growth after, like they've had bone, when you take the bone out, the bone grows back, or when they've had craniocervical fusions, the bone that's supposed to fuse doesn't fuse. What is the, do you have any recommendations for how to deal with either one of those things, of too much bone growing or not enough when, in healing in these surgeries?
Yeah, those are tough problems, and so that requires very individualized treatment. Not fusing is a very common problem that a lot of people with spine surgery get. And so it's not just Chiari patients, it's people who have spine surgery. So you might have heard of people who get multiple spine surgeries, right? It's failure of fusion because the bone's just not growing. So it's a very individualized problem. Same thing with overgrowth. Usually bone is very slow growing, so that is a less common problem, but technically it could happen. But if the bone regrowth is a problem and taking up space, then it could be removed again, right? The fusion failure is a little tougher because presumably the instrumentation was put in to help with that. And if it didn't work, it is what it is.
I think we've seen here the wide variety of issues and questions by all your great questions and coming from different angles here. I know we can and probably should go on for another 2 to 3 hours, but I think we're going to do so in a little bit less formal of a way. And let's give Dr. Huang a hand for her lecture.